The crisis has given us new ways of educating, and one of them is the webinars. And at the outset, I'd like to thank my colleagues from Leicester, Dr. Amrita Bajaj, the youngest and the most experienced radiologist in UHL, Dr. Samir Hanna-Jumna, consultant anaesthetist and intensivist, and our thoracic nurse specialist team, who all have come to hospital to join us today, Hayley, Joanne, Sarah. So over to you, Bhuvaneswari.
Okay, thank you, Sri. Good evening, everyone. So today's topic is going to be thoracic surgery during COVID-19. This is for all allied health professionals, including SCPs and nurses.
Thank you, Bhuvaneswari. While Bhuvaneswari's showing Samir's slides, Hanna-Jumna is one of our consultant anesthetists and intensivists who's been integral in this time of crisis where ITU had to gear up, get things done. The first ever impact when we felt it on us personally is when Sam was supposed to be doing my list and the list got delayed because he had to be to a crisis meeting when overnight London 2 ITUs were full. So that's how it started. So Sam, take us through what's happened and how it's impacted us as thoracic anesthetist intensivists.
So I'm going to talk about the anesthetic consideration during the SARS-CoV-2 pandemic. I'm a consultant anesthetist and intensivist in Glenfield Hospital. I've been in the management of both COVID and non-COVID patients during the last, actually, I wouldn't say few weeks because it's more than 3 months now. So it's been dragging for a little while. I will share with you my experience and we'll have some discussions at the end. So what does COVID provide? I hope this is going to be once in your lifetime experience. There is unfortunately concerns, especially with the deforestation and overpopulation of the planet, that epidemics will happen more frequently. So it's really vital to reflect on this experience and learn as much as possible for future management of anesthesia during pandemics and surgery and intensive care. So the current pandemic, as you know, did stretch the NHS to the limit like never before. And it's essential to use this experience because no simulation will provide this ever. During this presentation, I will mainly focus and try and discuss two major aspects, the organizational and the individual challenges for anesthetists. Most of the recommendations are based on documents published by the Royal College of the Anaesthetists, the Faculty of Intensive Care Medicine, and from our own experience. I recommend you familiarize yourself with the ICM Anesthesia COVID-19.org website. It has rich resources of information. So how are we going to get surgery safely back following COVID pandemic? Or what the document is called kicking on while it's still kicking off. So we'll start with the organizational challenges. And I would like to divide these into 4 different aspects. So are we going to get back to normality? What we need to consider before doing that, we need to be able to protect the staff and the patients. We have to be able to proportionate the PPE, and we have to bring back staff and resources to normal pre-COVID level. We also have to be able to prioritize our surgery. How are we going to protect staff and patients? So while some medical care can be undertaken remotely, anesthesia and thoracic surgery in particular is associated with one of the highest risks of exposure to aerosol generating procedures. So how are we going to safely provide this service and ensure minimizing the risk to the staff and our patient? Especially that previous experience demonstrated, we have a good evidence from MERS and previous SARS pandemic. Now, hospitals during pandemics can act as a hub for spreading infection. So it's crucial to create separate pathways for COVID positive, COVID negative, and COVID unclear patients. Ideally, we should have staff as well to treat either COVID or non-COVID patients, but that's very difficult. Certainly in our hospital, we relocated the breast surgery to the private sector. This is not possible with thoracic surgery due to important logistical issues. So what Challenges of having two parallel systems in the hospital. Well, challenges are a lot. The first, or one of the main challenges, is the ability to ensure that staff are infection-free. How are you going to provide that? There are multiple different ways. We've seen it, unfortunately. We had to deal with it in Glenfield. We had colleagues who got infected. This is happening less and less. It usually happened at the beginning of the pandemic, and unfortunately, to some of my surgical, nursing, and anesthetic colleagues, we are very fortunate that we haven't lost any of our colleagues, but some of them were quite unwell. We won't go into the details for confidentiality reasons. So how are you going to be able to provide that protection? We already have rolled antibody tests to all our staff. I think we started beginning of this week, since Monday, taking tests, but we haven't got any results back yet. But still, the knowledge is very limited, and it's not very clear if antibodies will provide immunity against COVID. So how is that advantageous? Well, we don't know yet. The research is still going, but it's more of an epidemiological study and analysis of how much COVID is spread in the society. So that will give us an idea about the spread. Antibody testing, swab testing, PCR testing, all these things you can do, but are they going to guarantee that you're not infected 100% of the time, all the time? I don't think that's possible. Other thing is distancing. So social distancing should apply to all clinical and non-clinical areas as much as possible. I'm sure you just witnessed the government announcement, was it yesterday? I think yesterday or this morning, about the face covering for patients and staff working in the NHS. So, and typical hasn't been communicated to the NHS trust bosses, but things are quite dynamic. So there is a lot of ongoing change all the time, and you have to try and keep up with the evidence as much as possible. Apart from that is protecting the staff, and finally having cohorting a staff who's going to deal with this very sick group of patients. This will put a very will put a lot of stress and stretch on this limited number of staffs, which can be associated with quite significant fatigue and sickness absence. So in order to return to normal and provide normal service, it has to be a gradual process. And this has to be run in a traffic light system, which is RAG, red, amber, and green. And that traffic light system has to apply into four major areas, the four S's, which are the space, staff, stuff, and system. So you have to move from red into green, into all these four major areas to safely provide anesthesia to COVID and non-COVID patient. So let's start with the space. As you know, critical care capacity and availability of critical care beds is crucial for cardiothoracic surgery provision. With current modeling in intensive care, we expected to provide an ongoing 5 COVID beds on daily basis in ICU. Also, we should be able to provide ECMO cover, as well as provision for emergency and elective cardiothoracic care, out of hospital cardiac arrest, cardiology, and other respiratory emergencies as well. As of today, when I was on call, we're still in theatre recovery with ICU patients. And this was originally part of the COVID surge planning, which we're still employing to provide care to COVID and non-COVID patients. This is very important, and it's essential because cohorting on different groups of patients will put significant pressure on space availability and isolation room capacity. So having a 10 COVID patient is easier than managing 4 COVID and 6 non-COVID patients, because you have to self-isolate these patients, you have to cohort your staff into different groups, so it varies a massive logistical difficulties. And let's move into staff. So the surge capacity in ICU bed provision was impossible without the exceptional support provided by theatre staff and staff from other parts of the hospital. And genuinely, me as an intensivist, I can't be ever so grateful to all of my surgical colleagues, nurses, all DPs, all other staff in the hospital, really, because their provision of care during this pandemic was extremely helpful. Without them, we wouldn't be able to provide all this intensive care. So you need to bear in mind this will be associated with increased risk of fatigue and stress and can have an impact on sickness leave. In addition, there will be a significant backlog of accumulation for annual leave, bank holiday, and the flexibility of working enumerated time and time required for educational and professional development. The third one is the staff, and this includes all the necessary equipment required to provide critical care. Shortage of stuff like drugs will have an impact on the ability to provide safe and good clinical care, especially in complex cases like cardiothoracic anesthesia. It wasn't unusual during the peak of the pandemic, actually, for us to modify sedation strategies due to limited propofol, for example, or other anesthetic drugs. I hope this is getting better now, but not back to pre-COVID level. The availability of appropriate PPE is crucial. Without it, we'll not be able to provide safe care. Also, the monitoring equipments, ventilated, borrowed by ICU, all these need to be relocated back to original theaters. And finally, which is really important, we need to make sure we have availability of ICU equipments to provide organ support, like renal replacement therapy, other organ support therapies that were required post-operatively or intraoperatively for some patients. The final stands for system, and we need to have a really robust perioperative systems in place to cover all aspects, including preoperative assessment, patient self-isolations preoperatively for 1 or 2 weeks, preoperative clinics, either virtual or face-to-face, images, and swabbing. This will put significant delay to provision of surgeries, so this needs to be factored into planning of surgery and waiting lists initiatives. Okay, so there are plenty more organizational challenges, but I think this will give you a framework of the major areas that we need to work on to get back to normal, really. So let's look at some of the individual challenges. This is me and my daily ICU kit. Sometimes I put just a normal surgical gown. Sometimes you can put the full body, but you can imagine, let's say, doing a 8 or 10 or 12-hour list in this costume. It's not going to be comfortable. It's not going to be fun. It's exhausting. So what I want to discuss in the major challenges is for anesthetists individually is airway management. I want to talk a little bit about invasive procedures, and I'll touch about a few others. So airway management is the major challenge for anesthesia and cardiothoracic surgery, in my opinion. The principles of airway management in SARS-CoV-2 patients should be safe, swift, and accurate. And what I mean by that, safe means the anesthetist and theater team should wear appropriate PPE for different parts or all of the intraoperative time. And wearing the PPE is part of it. The other part is trying to minimize the amount of aerosol generating procedures during intubation. It's not always possible, and that's important, particularly in thoracic anesthesia. As we know, a significant number of patients will require bronchoscopies, they require rigid bronch, they might need jet ventilation, double lumen tubes, lung isolation, suctioning, bagging, putting chest drains. So you have to try and minimize these as much as possible by discussing with the team. I don't think you'll be able to abolish all of them in all patients. And accurate means it has to be planned in depth as to try and make the first attempt the most successful. So even considering using video laryngoscopy for cases where normally direct laryngoscopy could be enough to minimize the risk of exposure and the intubation time. I wanted to quickly highlight the use of supraglottic airways. I think they still have a place for them to be used during cardiothoracic surgery, but I think their role is mainly, in my opinion, in general surgery or in the extubation phase of anesthesia. We do some spontaneously breathing thoracic surgery, so we can still use them. Are they going to be less aerosol generating procedure and more protective? The evidence is lacking both ways. So there is no evidence to support for or against. It's all based on an expert opinion. There is no published guidance on this issue, and it still has to be the judgment of the anesthetist. So you have to see how it sits in that patient, if it's going to give a bit of leak, a lot of leak, what type of surgery doing, how long it's going to be, or is it something, let's say you're going to use it at the end of the surgery, for example, you finished a lobectomy or a big thoracic surgery where you need a double lumen tube. At the end of the surgery on the extubation phase, you don't want the patient to cough a lot because that potentially can produce more aerosol generating procedure, and you just try and replace your double lumen or single lumen tube with a supraglottic airway device. Okay, so how are you going to balance the benefit of wearing PPE with providing efficient system and not unnecessary time? Did the slide move on? Yes. So how are we going to balance the safety and the efficiency of wearing PPE and providing efficient system, cut unnecessary waste? Also, working full PPE is not very comfortable experience. So can we minimize the time that we wear PPE intraoperatively? In thoracic anesthesia, to be honest, it's unlikely, as throughout the surgery, the lung will be exposed and require respiratory and airway maneuvers throughout. But it's important for us to understand that after a certain time following aerosol generating procedure, there will be very little viral load or patient aerosols in theater suite. This is called aerosol free time, and there is a formula to calculate it. But basically, in most theaters with capacity to provide 20 air room changes per hour, there will be negligible viral or aerosol load after about 20 to 30 minutes following an aerosol generating procedure. And I assume if you work in different places, you'll slightly have a different air exchange system, but most modern theaters should provide that facility or capacity where they do a 20 air room changes per hour. So invasive procedure, why did I decide to put invasive procedure? They are an important challenge, and especially that large proportion of thoracic patient will need invasive procedures like central line, epidurals, paravertebrals, and a few others. So the challenges with inserting these lines using PPE include the risk of healthcare acquired infections. So no matter how much you try to de-sterilize, I think having double gowns and all the mask and all the PPE will make this more challenging. It's not impossible, but it's more challenging. The other issue with them is the manual dexterity, because during all intubation, I personally use double gloves. So I take the top glove, clean, and then put another sterile pair of gloves to do the invasive procedure. So that definitely will have a bit of impact on my manual dexterity and sensation, which is quite crucial for a lot of these procedures, including epidurals, central lines, and many others. And finally, the communication challenges and the availability of decontaminated ultrasound machines. So I don't know if, I'm sure all of you have worked during the pandemic with face mask and PPE and FP3 mask, and you can see how challenging the communication through these things can be. Another remarkably high procedure, which is really important, is nasogastric tube insertion. We had real issues from significant complication following nasogastric tube insertions in COVID patients because a few of them went endobronchially, which sometimes you can't identify because people would want to insert them blindly by touching feeling technique, which is not unusual. The majority of NG tube get inserted that way. But if they end into the lung and they go endobronchially, we had 4 patients with pneumothorax, and pretty much all of them are dead. So it's a very high risk procedure and something that would inadvertently expose both the patient and the staff to high risk of complication and exposure to infections. So other challenges, I've already mentioned communication. As an intensive care consultant working in a COVID bay, I wear like protection for long part of the shifts. And on certain occasions, if I get a phone call and someone is talking to me over the phone using FFP3 mask, I definitely won't be able to hear anything. So how are you going to go across and manage this? We use different approaches, different ways, either using whiteboards and write to each other what we need, or we're using walkie-talkies or a few other things. But you have to bear in mind, you have to have a system in place, because during emergencies, one of the major issues is human factors, and these are mainly related to communication, situational awareness, and they are critical for teamwork and in preventing complication in anesthesia and surgery. So it's really important to understand that in the current environment, these factors can be impaired due to PPE, fatigue, and many other issues. and you try and minimize these and potentially mitigating them using checklists, feedback, and robust clinical governance systems. So other issues as well, finally, include difficulty in provision of training, taking breaks, really important. I mean, I haven't seen an anaesthetist who can't have like a 3 coffee breaks and half an hour list. So never mind having to do a whole list without going for a coffee break is really a challenge, and refreshments. So usually we look after ourselves and our trainees well, which is really important because you have to have that ability to focus on your task. But these are going to put a lot of strain and exhaustion and fatigue into the system. So never mind doing all these, having to train someone, and it's not just providing the training to them, is bringing these staff into high-risk area, because potentially these young doctors and nurses and ODPs can get infected, and so you have to provide a very safe, robust system, really. So I'm almost done. In summary, I want to say COVID-19 has thrown significant challenges to the NHS. These are mainly organizational and individual. So the provision of 2 parallel systems, providing care to COVID and non-COVID patients, the balance between safety and efficiency, protection of staff and patients from infection, individual challenges are many, and they are related to steps taken to minimize patient and staff risk from exposure to COVID-19. In addition to all this, we still don't have very clear data on the mortality of COVID-19 positive patients that require non-COVID related medical care. There are very robust documents to guide timing and urgency of care during COVID-19 pandemic. I don't know if Sri is going to talk about these, but I believe this is work in progress, and the system needs to be flexible to adapt to these changes. So I want to thank you for joining and listening, and I'm happy to take any questions.
Thank you so much, Samir. And we will open the questions to everyone. And we have 5 minutes, and please unmute, and one by one you can ask question, please. Anything you want to add, Sri?
No, all I can do is to thank Sam for giving a fantastic overview. And are there any questions for Samir? You stunned them to silence, man.
I stunned them into silence, I know.
Hi, can I ask you a question?
Sorry, there is a question for you, Samir, from Nisha Nair.
Someone want to ask?
Hi, Samir. It was a nice presentation. I'm from cardiac. I just want to know, is it same for cardiac patient intubation and aerosol and everything? Is it the same?
Yes. So all the guidance apply to cardiothoracic cases and all cases pretty much. So in our hospital, we provide this also to the general patient and vascular. Intubation by aerosol generating procedure. So you really need to take maximum protection to protect yourself from COVID.
All right. And is it 20 minutes to start the surgery? You leave for 20 minutes for aerosol to clear the air?
It depends on what you've decided as a team to provide, but clearly the Cardiothoracic Society guidance is no substance and CPA agents for PPE. If you think that it's going to be operated with the full PPE, maybe you should consider taking the patient to theatre, waiting for 20 minutes, half an hour, then starting the procedure. So this has to be decided by the surgeon operating on that patient.
Okay.
Bearing in mind, we don't know how much aerosol procedure is to me if they're using a saw. So they shouldn't use mechanical saw. Well, saying shouldn't is a strong word. Maybe they should consider not using one.
All right. Thank you very much.
My pleasure.
Yeah.
Can I ask a question? It's Annie from Papworth Hospital, Cambridge.
Hi.
Hi. I just wanted to ask, how did you manage, because you were talking about managing the COVID positive patients plus COVID free patients. How did you manage staff movement? Because there are particular staff you can just, they can be just allocated to that particular patient, but others like physios and the consultants, how did you manage this moving from, did you have to, I don't know, how did you manage it? Would be nice to know.
It was very challenging actually, but we have an extremely helpful team. All our nurses and doctors have, to be honest, been working 100%, 150%. But what we like, it depends on the workload. Obviously, we had to expand our rota and the nurses' rota, and that was based on support provided by theatre nurses, ODPs, our colleagues from surgery, medicine. So when we start the day, we split into different teams. And these teams will be cohorted into either COVID or non-COVID bay,
Okay.
and stay in that bay for that shift. But they will be so they will be a nurse and a doctor in charge of everything. So we have like a command and control room which oversees everybody, but we'll have a dedicated team for COVID and non-COVID patients. And that's by itself throws a lot of challenge. So when I said like managing 10 COVID patients is much easier than having two groups of 5 and 5,
Yeah.
which are COVID and non-COVID, because it will dilute your staffing, especially in intensive care.
Yeah, sure. Because we need to do our activities, regular activities, plus managing the COVID patients. I'm sure it's a challenge, but it was nice to know that. Thank you.
My pleasure.
Okay, do we have any more questions, please, for Samir? Thank you, Samir. That's it. No more questions for you, Samir.
Thanks very much. Thanks for listening.
Thank you so much.
So Amrita is the live wire which keeps our MDT going. I've known her for 10 years. She's the most senior cardiothoracic radiologist in University Hospitals of Leicester, and her experience in thoracic imaging is quite vast. And I've managed to convince her to give away her Saturday evening for our benefit to share her wisdom on imaging in COVID. Thank you very much, Amrita. One quick polite request to the participants: don't feel obliged to keep your video on. This is a lesson I picked up from our president yesterday, who's also on the call. He said we don't need to be all staring at the screen. We can chill and have whatever we have in our hands and enjoy the evening and listen to the webinar. So don't feel obliged to keep your video on. Over to you, Amrita.
Thank you, Sri, for that very lovely introduction. And thank you to the organizers to invite me really to give this talk, and of course for everybody who's logged in on a Saturday hang on guys, I'm trying to work out. Okay. So it was a very, very lovely presentation before me. So radiology is going to be more chilled out. So the rest of you want to go and get a glass of wine. I think this might be the time. So here we go. The most important thing to remember is that COVID, once it came, it was one of those things that none of us really knew much about. So the guidance changed as more and more information came, more and more data came. The radiology department, just like every other department, has kind of changed with what we are doing in terms of imaging. But one of the key lessons we've learned is that in terms of screening, there is actually no role of radiology, either chest X-ray or CT. And hence you'll find the guidance, which has typically come from the BSTI, which is the British Society of Thoracic Imaging, which is where I've taken the slide from. It really now has updated it to say there is really no role for CT, which is a more sensitive modality for any screening. But of course, there is a big role of radiology, there's a big role of imaging, but that is totally to do with patient management. So I can't stress on this again, that CT is not sufficiently sensitive to exclude COVID on its own in asymptomatic positive carriers. Why is that? Because you could take an X number and we don't quite know how many of these will be positive. That data is still not there. For example, we know that the gold standard is PCR testing, but we also know that up to about 60 to 70% are the only ones which will be positive. In other words, we would have still 30% who with PCR may be negative. But in CT, we don't know, but what we do know is that it's significantly lower and it's very variable. So it's really got no role. And with that caveat comes my presentation. So what I'm going to really show is what really imaging is offering. So what is really the cost of imaging? Now, if you met a radiologist in the past, in the pre-scenario, in the pre-COVID, all they would bang on about is, hey, do we really need to do this test about increased radiation exposure? That has become the least important if you're talking about COVID. We're talking about real lives. But this is indeed a cost with anything which is related. What is the most important is that the risk, if you're thinking about COVID and if it turns out to be positive, is to the other healthcare workers and other uninfected patients in a department which was traditionally not geared for this kind of scenario. So the whole thing has changed, and I'm not going to go into details because Samir has gone into much detail about how things changed. But what has changed in radiology is that now we've got a clean scanner, we've got a dirty scanner, and we've got to factor in the time for cleaning. And the time for cleaning can be up to an hour. And the only time, as I've said, we're not really using it for screening, we're really using it for patient management and ITU patients and really sick patients. Every time a patient comes in, from the time they arrive to the time you clear the corridors coming into the dirty scanner, to the time they leave and the next patient comes in, we're talking an average gap of 1.5 hours. If you think of a radiology department throughout the country, which has already been stretched beyond comparison for every possible thing, from the number of people working in there, from the demand and the capacity, you can imagine how much of a problem we are talking about, not just in terms of risk, but also in terms of morale of all the workers who are working there, but also in terms of the actual COVID patients who are suffering. It's a huge, huge problem that we're going through at the minute. And the guidance related to cleaning and downtime is also changing in radiology. For example, me, who's an interventional radiologist, and we know that a lung biopsy is an aerosol generating procedure. It was thought to be that if you go in there until recently, until May, when there was a lot of environmental exposure of COVID and the transmission was at its peak, it was thought to be an hour that you had to clean up after. And now slowly they are thinking that 20 minutes is going to be enough. And that's not just related to the number of times of the air circulation, but it's thought that the risk is so minimal and that you do want a throughput of patients, that it's thought that that should be an accepted minimum that we could do. But can you see this is not really based on something that has been trialed in the past? So there are lots of challenges that we have to go through. So I'm going to really start now, the rest of you can just chill, by showing what a chest x-ray can look like. So every patient that I'm showing in these slides are all patients from Glenfield from our experience. You could be COVID positive, and as I've just said, we don't use it as a screening test because you could be completely normal x-ray. But what's the classical appearance? The classical appearance is thought to be peripheral and basal airspace or ground glass shadowing. Ground glass is more difficult to appreciate on plain film. So in plain films, we tend to use the word airspace more often than ground glass. So this would be the classical appearance. But the problem here is, when we see this, do we mean that this is COVID? Well, if you had shown me the same two patients that I put here, which are so-called classical, if you were to show me the same films in January of this year, exactly the same, my differentials would have been as variable as saying that this could be, if I had previous films like that, this could be non-specific interstitial lung disease, or it could be non-specific evolving infection. What I'm trying to say is what we are thinking of as classical is so non-specific that it's only based on the clinical suspicion. And yet, as you know, when COVID came, all the other diseases remained just the same. So the diagnostic conundrum for a radiologist, if at all, worsened and became even more. So let me show you a few more examples. This is a couple of other examples. So as you can see in this particular case, all you saw is a little patch of shadowing here. This was another example of just bibasal non-specific interstitial shadowing. And then you look at this patient, which has got literally wishy-washy, what we would in the past use the word of dirty lungs, which is infection in a COPD patient. But in this case, these are all COVID positive patients. And this particular thing could just be thought of as encompassing the same thing, but it all actually was TB, old TB. The patient had old TB and COVID-19. So again, I'm showing all of these COVID positive, all of them presented like this, but they could just as well have been anything. Look at this. So it just doesn't have to be always involving both the lungs. It could simply be unilateral. Like in this case, as you can see, This is a unilateral patch of ground glass or airspace shadowing in one lung. The other lungs is completely normal. In this case, you could argue that possibly there's something there, but because I think it's the way it's projecting, but actually it could present equally unilaterally. It doesn't always have to be peripheral the way we describe it in the so-called classical appearance. So even the classical is not classical, but then let's look at some other patterns. Can you see? These just a little couple of nodules sitting there. Look at this case. It's almost a blob there, a blob which is not even peripheral. It's very perihilar. If you gave me this X-ray last year and you gave me the history, this patient is short of breath and has got pedal edema, I'll say this case is a classical case of heart failure. So again, you can see the diagnostic conundrum that a radiologist has. It could equally be mass-like, where you have little, nodular or rounded areas of consolidation. And in this case, you could see multiple nodules and some interstitial shadowing. So, in another scenario, you could equally say that this could be metastases or mass-like. Then it could not just necessarily be patchy. You could have it involving virtually a whole lobe. As you can see in this case, the left lower lobe, this case, the right lower lobe. It doesn't always have to be in this fashion. You could have a couple of other examples where it's evolving and it's becoming organizing. So some of the patients may be actually suffering at home, and by the time they present to the hospital, they become more in an evolving stage. So we normally tend to see this organizing pattern usually a week or so later. But again, data is coming in here. It's not always the case. Some patients may just have this interstitial shadowing or a patch of shadowing, and then they become completely normal and they disappear. Whereas others, depending upon the way they clinically, manifest, some of them as they become a bit poorer, they can become more organizing in this case. So these are all classical example of organizing, and organizing is when some bits of it start to heal, whereas other bits and become chronic, whereas other bits are still active. Okay. So what we do know is that it's unlikely to be COVID in the presence of pneumothorax, or if there is cavitation, or if there is bronchogenic spread. We use a typical thing called tree in bud. If you get that, it's very uncommon in COVID. You don't really get that bronchogenic spread the way you would get it in, say, TB. You don't often get lymph nodes, and you not very often get effusions, despite the fact that apart from pneumothorax and cavitation, I've seen all the other patterns. So you could argue at that point they were not biopsied. Were they real just because of COVID, or was it COVID and another community-acquired infection, which is often also seen? Okay, so as you can see, there is a big diagnostic conundrum. You're not going to use it for screening, and you put in a request. So how can you help the radiologist? You need to talk about what is the level of documented suspicion of COVID. Does it have the classical features of raised CRP and lymphopenia? And give every other relevant history. Is there a smoking history? Are you truly thinking of anything else, which is a malignancy or another community-acquired infection? So put in all the information to help the radiologist make the report. Then brings the next thing. When do we need the repeat X-ray? You don't need the repeat as far as the current guidance goes. As in, do we just do it just for the sake of following it up? No, you need a repeat if the disease is not going exactly as you thought it would, and you're thinking of alternative pathologies, or you're using it as a way to kind of help you in the clinical management, which we do all the time for the ICUs. So I'm now going to give you a couple of real life cases and how they progressed and how variable they are. So let's look at this lady who's an 85-year-old female. So she's old and she's got a history of myeloma, 2 major risk factors. And as you can see, on the 4th of March, her chest X-ray looked, she was COVID positive and she was remarkably normal. And if you remember, on 4th of March, there were not very many COVID tests available at all. So look at it on the 20th. The lady by that time had deteriorated, was an inpatient. And for those of you hawk-eyed ones would have picked up that she's got this big blob of consolidation, which is occupying most of her right lung and a bit which is seen in the left lung. This lady deteriorated pretty rapidly, and her lungs showed lots of organization and bilateral quite extensive changes. And as you can see, she did not make it, and she died on the 24th. Now, this is a pretty good example to show that from normalcy to extremely abnormal matched her clinical progression. But that is also something which we have seen is often not the case. You could have somebody who could get better, get worse and then get better, but the chest x-ray could remain remarkably quite ferocious looking. Let's see another case. So this patient had, again, all the other risk factors. He had obesity, he had diabetes, he was an ex-smoker, and on the 21st, when he presented, again, a pretty unremarkable x-ray. On the 26th, within 6 days of it, which is less than a week, you can see that there's some ground glass shadowing. He actually got quite poorly after that. And if you notice this case, he is actually an ITU patient, but despite him turning an ITU patient, can you see the x-ray doesn't look very bad? So even though he clinically deteriorated, the chest x-ray didn't show it too bad. Luckily, he was one of the guys who got discharged quickly. Again, I'm trying to show that even though we use it for clinical management, it must be done for each individual patient, because the imaging is not quite matching the clinical picture. So this is the BSTI tool, which I put in by, which was basically when we didn't have much PCR testing and there was a lot of reliability on chest x-ray. And this tool, which I'd encourage all of you to kind of see on the BSTA website, was really based on you had to have a high clinical suspicion. And then if the patient was seriously ill, which was described by SATS less than 94 and news score greater than equal to 3, then you almost always led into a chest x-ray. And then after that, I'd let you not go into the details of it, but basically told you what to do from then on. But if you notice, if the patient was stable, you did a chest x-ray only if clinically required. But either way, if you did it, then based on the chest x-ray, you decided whether to discharge or to self-isolate. Okay, so that brings me to the next flavor. So you've seen lots of pictures on chest x-rays. Let's talk about CT. CT picture, exactly like I said in the case of chest x-ray, is that if you had focal unilateral ground glass opacities, which progressed to bilateral peripheral subpleural opacities, that is thought to be classical. You can have features of organizing pneumonia, as I showed you in chest x-ray, but they tend to be more ferocious looking on CT. And septal thickening and crazy paving in is another classical pattern that we see on CT. So let's look at this case. Completely or relatively normal. For the hawk-eyed ones, you may have seen that there is perhaps a little atelectasis. If this patient came to me as a pre-op, I would say pretty unremarkable, just bisal atelectasis. But as you can see on CT, which is far more sensitive, this patient has got a lot of interstitial pattern. It's not atelectasis, and a little airspace shadowing, which would be thought of classical in this COVID time. So let's take a couple of examples. 67-year-old, the chest x-ray said 10 days of flu-like symptoms, and on day of admission became increasingly short of breath with a non-productive cough. So they were thought this is COVID. The chest x-ray was reported as highly suspicious because it showed in this, with that history, you've already got a high level of suspicion, basal and some peripheral opacities, mainly on the left lung. But the patient then showed worsening. He then showed worsening breathlessness, and this triggered a CTPA. And as you can see on the CTPA, initially, that thing progressed to becoming worsening and becoming more confluent consolidation on a background of ground glass change. And as you went higher, this is at a slightly higher level. As you can see, this is at the ventricular level. At the higher level, it became true ground glass. This would be considered in this current environment classical COVID picture. So let's look at it. It was a CTPA request. Look at that. When you did a CTPA, which is a thing that you tend to do to look at thrombi, you find that this patient had several thrombosis that was seen, which is another thing in which imaging can really help, because thrombosis is very commonly seen with COVID. And that is something, again, which we have discovered as the COVID picture unfolded. Let's look at another case. 50-year-old presented with abdominal pain. And as we are talking to the surgeons, I thought it was best to now show at least a couple of examples of so-called abdominal pain and acute abdomen. GP had treated it for UTI, but she then became quite ill. So the chest x-ray, well, there was a patch, a blob. You know, you could just about say that this is community-acquired pneumonia. When you actually did the CT, you can see how sensitive it is. Classical picture of COVID in this current, peripheral, bibasal, ground glass shadowing. We didn't find anything on the CT in terms of the abdomen apart from splenomegaly, which can sometimes be associated with pain. Another example, this patient had low suspicion of COVID, but came with tender right upper quadrant. It was thought, is this an acute abdomen? Is this a gallstones? Is this pneumonia? So a chest x-ray on the day of presentation showed a mild peripheral opacity right lower lobe. And for those hawk-eyed ones of you might see that there is a bit of ground glass change here. When the CT or MRCP was done, because the patient was thought to be having gallstones, even on the MRCP, this is an MR picture for those of you who are not familiar with it, and which is not very sensitive at all for looking at the lungs, you can still see that there's some blob sitting there. This was very clear on the CT which followed it, because on CT it was thought to be as, this triggered a CT, and that showed that the classical picture of COVID. So these are, as the patient became poorly, and this is exactly what happened. It started off as more extensive pictures. He became the peripheral GGOs with more dense consolidation, and then higher up it became even more dense. This actually progression took place over a few days. This was literally over a period of 2 or 3 days. The same patient is actually, the other thing that we found was that the same patient's 59-year-old dad, at the same time while he was in hospital, was admitted in ITU. And this is the other pattern we have noticed, that a lot of patients who came to the hospital, people living in the same house, especially older aging parents. I wouldn't really, for most of us who are sitting there with 59, I wouldn't use the word aging, but certainly the older generation was presenting at the same time. Okay, so I brought about the fact that it can be so non-specific. So when is COVID not COVID? So this was another patient who came in with a query COVID. He was admitted with shortness of breath, fever. He had a productive cough, and not everybody tends to get a dry cough. This was the clinical picture. And I do not know if any hawk-eyed ones might have already picked up what this is showing, but has anybody had a thought? I'll just pause there for a second. But really, there is nothing going on in the lungs, but as you can see, the hyla are pretty prominent. So this turned out to be a type 2 sarcoid. And when the lungs were scanned, it showed that there were some ground glass pictures. So was there sarcoid and COVID in these cases? So that is the other picture that we are seeing. Not only are people turning up with other diseases, but they are then weakened in immunity and turning up with coexistent COVID. So I've just tried to really show you, the whole spectrum of patients that can come and the different conundrums that we can have, and then also typically what has happened, and in terms of the BSTI BISCAR combined thing about what to do with acute abdomen. So in the month of March and April, every patient who came in with an acute abdomen, the guidance was that we should do a CT of the chest at the same time. And the rationale at that time was that there was high community spread of the disease. There was very poor testing. There was variable turnaround times, and we had an acute abdomen. So at that point, a CT chest was used in the algorithm to help decide that if even the CT chest was negative and the patient had to be taken into theater, and even though the PCR may not be there, then you could kind of take a rationale to say that possibly at that point, it was safer to do so if you didn't. But now what has happened is this guidance has now changed, because it is clear that as you know, that the pre-op CT could clearly be normal even in COVID carriers, and there is more better turnaround times, better availability of the PCR testing. So the current guideline has changed, and it is thought that we don't need a CT chest pre-operatively. Some may argue, especially the surgeons, especially Sri, who and me and he have discussed several times about this, but the bottom line is this guidance is changing for all of us. And this is based obviously on the rationale, although the common sense approach would be if that too is negative, then hopefully it adds to it. But the truth is you just don't know. So this is hence the updated guidance, which has also come from the three colleges together as well, that as the community prevalence has dropped and the availability has improved, so we don't really need the CT chest. And that's again, the same thing happened for preoperative CT chest. So that brings us the next question. What lies ahead? You can see that we didn't even know what came along, so we don't know what lies ahead. Practices have completely changed. The new normal has changed, and purely from talking from radiology point of view, what are we going to do as things are going to unfold? There will be more COVID surges. What is going to happen to the patients who are already there? How are they progressing? Do they all come back to near normal chest x-rays and CTs? Are we going to have more and more cases where the patient goes to a so-called clean scanner and then turn up having COVID? What do we do in those scenarios? So there are a lot of questions, a lot of unanswered questions, but we are dealing with it as it goes along. We've just last week had our first follow-up COVID clinic in which we hot reported the x-rays. We had to have change of duty rotas. We had to have change of certain rooms which became purely COVID chest x-ray rooms. So as you can see, we really don't know what lies ahead, but it's been a fantastic department and it's been a privilege working with them. And I think I kind of say the same thing that Samir said, that we've all changed. We've it's something that we don't know much about. So that's really it. I have to thank my colleagues who have helped me put this presentation together and give me all the live cases, a lot of these together, and of course the BSTI slides. So I would welcome any questions, and I thank you all for patiently listening to me.
It was a fantastic run through the radiology of COVID, Amrita. Thank you. Do we have any questions for Dr. Bajaj?
I've got one, Amrita, if that's okay.
That's all right. Yes, please.
Hi, thank you for that. It was really, really good. Obviously, do you think the hesitation with the surgeons for not doing pre-op CTs is due to the PCR testing not being 100% accurate as it was?
That's what I alluded to right in the beginning of the presentation. So like you already know that 60 to 70%, depending upon where you took it, how you took it, at what stage of COVID you took it, the sensitivity of the COVID is variable. And the common sense approach would be that if at that point you got it negative, you've got a low clinical suspicion, and you got a CT chest also negative, you'd have several things telling you negative, so your confidence interval increases. But unfortunately, we don't have the same data for CT as we have for PCR. You could have it's just an unhelpful spoke in the wheel with more harm probably caused in terms of probably the way to organize it, and also in terms of really not knowing. So because the workflow has to be smoothened with maximum benefit to the patient, I think hence the guideline has been changed. But I can see the common sense would be, hey, come on, let's put another wheel and say, okay, that too is negative. So we're kind of more reassured.
I think that's it, isn't it? It's that confidence. We trust our radiologists at Glenfield, you see.
Thank you. Glad to know.
Thank you.
Sorry, there is a question for you from Kudai. Thank you for the informative presentation. From current experience, how long does it take for a radiological changes of COVID-19 pneumonia to resolve?
I wish I knew the answer to that. We don't know. So you could actually have, and I showed two cases similarly, you could have a patient which goes from a ground glass change and within a week not metamorphose at all into anything, because you haven't really taken a chest x-ray if you don't clinically need it. So we don't know the answer. The data is very variable, and most of the data that has come out of China and a few other countries is based predominantly on CT, and are normally, if you remain completely well, we don't know how it progresses. And when it does progress, it can progress so variably. So I would love to say I know the answer to that, but I don't. Yes, Samir.
Thanks, Amrita. Lovely presentation. I'm surprised that a negative CT scan doesn't act to the negative predictive value of a negative swab, because we know like 2 and 3 swabs, all of them negative, will significantly improve the sensitivity. So with the number of CT scans preoperatively we've done nationally, we managed to get any data about how useful is a negative CT preoperatively with a negative swab to improve the sensitivity of the test?
This combined statement from the three Royal Colleges came following some of the data. The data we, as far as Glenfield is concerned, because it was a multinational, we all the hospitals put in. So I don't quite know the result of it, but based on what the initial data was, it was that it's not going to add to it. I can clearly see your question because even as a radiologist, who I can see the common sense approach to it. So in answer to your question, I would say the initial data and based on what they have told us from the Royal Colleges, I would like to believe that probably not. But I don't know the exact data, what it was and what the hit rate was with the CT. Having said that, in the next couple of weeks, colleges are going to publish all the audit data that we sent in for the pre-op CTs, because we haven't stopped doing it at the minute in Glenfield, as you know.
No, that makes sense because I haven't seen anything published. So to have some evidence, it's useful to avoid all these scams.
Yes, absolutely. And the workflow, I'm sure it's the same for the rest of the hospital. The workflow is now suddenly we've reached into what is already completely gridlock in radiology, because the normal patients for 3 months who had just stood and nothing had happened have now come back and COVID is still there. So you want to make it most efficient, whatever you do, COVID and non-COVID.
Thank you.
Sorry, I have a question for Samir. I forgot to ask. Is this the right time to ask or should I ask later?
You can ask quickly, yes.
Okay. Just with regards to the management, I'm not 100% sure about this two different ways of managing. What is this proning helping and how is the ECMO? What is the most effective and how did you face your patients in those two ways of management? What is the best way?
The best way is a personalized patient ventilation strategy. What I mean by that, in Glenfield, we do proning a lot.
Okay.
Not new practice to us. We used to do it pre-COVID. It was very helpful during the COVID. I would say the majority of our ventilated patient and even some ECMO patient, we did prone on daily basis. And we did have a dedicated proning team to do it because it's a quite demanding procedure.
Yes, okay.
In terms of ECMO, it's useful, but you have to be very active because ECMO is very complex in these patients and it will drain your resources and it's associated with a lot of bleeding, clotting problems. So I think the survival from ECMO or from COVID on ECMO in our center, maybe I would say about 50%. I don't want to give you like a false statement because we don't have the full data yet. And if I'm optimistic, I would say 60%. And I think nationally, and I think nationally that will be the figure. But I can't tell you anything yet till we have all the data in front of us.
Okay. In case of proning and ECMO, sorry to ask you one more question. What's the time duration? What was the quicker way of, how did you see the difference of time duration on the ECMO or proning before you could get the patients better?
We do it as early as possible and we do it for 16 hours a day, unless there is a complication or they know.
Thank you. Thank you, Samir.
Thank you, Samir. Thank you, Amrita. So thank you so much. Let's start with our next presenter is Mr. Sridhar Rathinam. He's a consultant thoracic surgeon. I don't need to say anything about Sri. Everyone knows about Sri. And he's a special man as always. And he works as in Glenfield Hospital. Sri, all yours.
Thank you very much. Let me just get my slides. Good evening, and thank you for staying so late on a Saturday evening to listen to us. And a big thank you to my colleagues, Amrita and Sam, for putting together a lovely presentation. So mine's going to have a little bit of overview of educational content because I'm aware that there are quite a lot of cardiac surgical SCPs in the audience. So pardon me if it is too basics. So this is Leicester, for those of you who don't know, a very historic city in the Middle England. And this is our hospital. We are based, the cardiac thoracic unit is based in the Glenfield Hospital. And this is the lovely bunch of team which we work with who make our everyday pleasurable when we go to work. I just want you to hold this thought. The bulk of our work is with cancer patients. This could be primary lung cancers. These could be patients who have had a cancer elsewhere and have had secondaries in their lungs, which we resect for metastasis. So there is 60% of the patients who we deal with are in an emotional stage because of cancer. And then there are other patients who we deal with. So how does COVID affect all of us? It has affected our pathway. It has affected our healthcare professionals, as Sam and Amrita alluded to earlier. It has an impact on our performance because normally we measure success by how many patients do we get home, what is a 1-year survival, what is a 5-year survival. So all of that is going to be affected with COVID. And finally, we are all in this profession because of our patients, and it has an impact on the patient's experience. So what's the role of surgery in normal circumstances in thoracic surgery? We help diagnose cancers. We are part of staging. We offer curative surgery. And more importantly, in those patients who need a quality of life, be it cancer or advanced emphysema, we palliate their symptoms. Surgery is a risky business in normal circumstances. You have to reduce harm in pursuit of excellence and strike the fine balance. Every time we have to go and argue with our anesthetic colleagues saying, look, we are doing it in the patient's best interest. Can you get the patient to sleep? Because the bigger picture is, are we doing the right thing? And it doesn't get more riskier than ever with this current pandemic. Is surgery appropriate? Why are we doing it? That's a question which we ask all the time. The second question is, can I do what is required? And is the patient fit for surgery? So what's had an impact? COVID has had an impact on the operability aspect, because we could operate on an 84-year-old fit lady who's driving around Northamptonshire going from meeting to meeting. But that's the cohort where we have said you have to be shielding and staying indoors. So the operability criteria have changed because of the pandemic. And then do we push the boundaries in terms of resectability? Can take chest walls out. Will we do it? Because there is no ITU beds to put these patients should they need an ITU bed. So all of that has had an impact on our day-to-day activities. We are part of a multidisciplinary team. The way we work in an MDT has changed because of COVID. We no longer go physically to MDT if possible. We dial in with video technology, just like this evening. And the MDTs also have evolved. Northampton is one of the hospitals I go to. They've created an ethics MDT because they know operation is going to come with a higher risk, but in the grand scheme of things, we have to let the surgeon operate. So all of these things have evolved during this time frame. We're part of the diagnosis, and if you look at the list, quite a few of them are aerosol generating. This is what we need to know before we operate. What is their exercise tolerance, respiratory function, cardiac function, their comorbidities. This is the BTS guidelines, which we use to choose patients for surgery. And if you look at the left-hand corner, the total lung capacity and residual volume are all measured by plethysmography. We can't do plethysmography now because of infection risk, cleaning, and all those things. We can't do cardiopulmonary exercise testing to see what their reserve is, again, for the same reason. So risk assessment now is using surrogates, and you then have to balance the risk versus the benefit as opposed to having something objective. Thoracic surgeons are very interested in the FEV1 and the predicted values. It's very calculated. And most units would say if the FEV1 is low, you don't put them through an operation. Leicester is slightly different because we have a big practice of lung volume reduction surgery for emphysema patients. So we know some patients benefit even if the values are low. But these are the patients who are at a higher risk of having a problem. And in a pandemic, these patients are told, look, we won't operate. The other cohort is patients who have had previous cardiac problems who need an ITU bed just as a backup, but there is no beds. So all of this has made a big difference to what we can and can't do. There are hospitals in the United Kingdom which are down to 2 lists a week, when in the normal circumstances, they would be doing 10 lists a week. This is the BTS algorithm. But to get to this algorithm, there are tests which we can't do. So all of that has made a significant impact on what we can do. Consent is a key process when it comes to surgery. And we have to talk about alternatives and risks and benefits. But as we've already told you, we don't know what is the risk of having surgery during a pandemic or what the patient's risks are going to be. This is the usual risk which we quote patients based on national averages. But all of this is out of the window if the patient gets COVID and they convert perioperatively. We do wedges, or we would do segmentectomies. In normal circumstances, a segmentectomy is done for cancer with all the lymph nodes, all the feeding vessels. But a quicker operation in a pandemic may be just a wedge. Take a cake slice with the cherry in the middle, and that gives you the diagnosis. It's a curative resection. Segmentectomies have a better outcome. You're conserving lung and you're doing a good cancer operation, but it takes time. So when everybody's wearing a PPE and you're struggling to breathe in an operating room, do you want to go for the gold standard, or do you do a quick operation which gives you the best benefit? We choose to do the latter, unfortunately. Lobectomy is what is commonly done in the UK. A lot of units do it thoracoscopically, but VATS raises the possibility, is it aerosol generating because the air is funneled through a small port, or it also takes a longer time than an open operation. I can do an open lobectomy in 29 minutes, skin to skin, but a VATS lobectomy takes 120 minutes. So there is a difference. So that's changed things. Do we do a pneumonectomy in this pandemic, leave a patient with just one lung and they become a sitting duck for a COVID infection? So all those things play in. Normally, we would do a sleeve resection to conserve lung. Sleeve is where you take part of the lung with the main windpipe and join it together because it conserves lung and it is a good cancer operation. But then the infection risk, I know Michelle is on the audience, the work of physiotherapists becomes difficult after a sleeve resection. So you have to make those decisions in a judged, timely fashion. So that's an illustration of a sleeve resection. Chest wall resections. So cancer going into the chest wall, you would do an en bloc resection and reconstruct them. It has a good survival, up to 50% if you get an R0 resection. However, is that the right thing to do in this pandemic? Because these patients may require an ITU as a backup because the chest wall mechanics is lost, their breathing is changed. So you then have to make a decision and send them to the oncologist for radiotherapy, which probably is a substandard treatment in this setting. The VATS lobectomy is less painful, it's good, but you have to choose when and where in this time frame. So you can compare an open lobectomy to a uniportal VATS. So the incision is as big as half my index finger's length, whereas the lobectomy done through a thoracotomy is bigger. So all those things come into play. The other cohort which Leicester is quite famous for is lung volume reduction surgery. We use that technique and the principles in patients who have very poor lung function with a cancer in the damaged part of the lung. So FEV1 of 30%. I've showed you a slide earlier saying you should have 40% of FEV1 after you resect the lung. So this patient is 30% FEV1. Will you offer surgery? In Leicester, we would, because we know the tumor is in the part which does not have any perfusion or ventilation. Taking it out will help the patient. But is this the right time to do this operation? So these patients unfortunately have to wait. Adjuvant chemotherapy is part of our cancer treatment where patients of a certain stage are given chemotherapy after surgery because it offers a survival benefit. But you're giving the patient a double whammy. You've had surgery, then you give chemotherapy to compromise the immunity when they are susceptible. So this again has stopped. So all of these things, plus the palliation which we do for endobronchial palliations, all are highly aerosol generating. Laser, PTT, debulking and suctioning, because we use a rigid bronchoscope and the anesthetist uses a jet ventilator which basically blows air straight onto the surgeon's face. You wear all the PPEs, but still it is a higher risk procedure. So you have to be selective as to where you will do these things. That's just a quick outline of where we would be called for emergency airway obstruction and salvage. As you can see, all of that involves aerosol generating procedures. So the surgical decision making is to always take calculated risks. You predict an avoidable death from surgery and a certain death from pathology. Yes, 2% of patients having surgery will die with a lobectomy, but if we didn't do that operation, the cancer will grow, spread, and die. So we have to make the decision as a part of the MDT, and we shouldn't deny the patients who benefit for the sake of the minority that do not survive. You have to give a honest predicted mortality, and this is where informed consent comes in. Now, I just want to highlight on LVRS. LVRS is a procedure which is done to reduce the breathlessness and improve exercise tolerance so that patients can live a bit longer with a good quality of life. We are a large center. We've been doing it for the last 20 years. This is what the benefits are. So if a patient has upper lobe preponderance and poor exercise tolerance, doing volume reduction gives them a good outcome. We do practically about 40% of what is done right across the country. But all these patients have now been told, as you can see, that's completely damaged lung. You can see on the right side, there is no perfusion at all in the upper lobes, and this is all squished. So removing this will expand this lung, and then they breathe better. But we've put a stop to all of this. When you're prioritizing cancer patients, because of the pandemic, these patients unfortunately have to wait. The same thing with endobronchial valves, which we do for LVRS, that's again stopped because you won't know whether the obstruction and collapse is because of the valve or because of the COVID pneumonia. Chest trauma is the other area where thoracic surgeons are involved. Both these patients survived, by the way, but we've seen a significant reduction in the stabs and assaults and road traffic accidents. But there are still elderly patients who fall and crack their ribs and end up getting admitted. So the volume of trauma patients which we see has definitely come down with the pandemic. So it's making a judgment in a pandemic situation and operating well. So in the first few weeks, we were only operating on fit patients who would go straight to a thoracic HDU. Our unit normally does not send our patients to ITU. That is reserved for patients who are elderly, who have cardiac comorbidity and all those things. Most of the patients go to our HDU and go home day 3, day 4. So surgery is complex. Sam alluded to this earlier on. In addition to the technical skills and multitasking and decision making, we have to recognize patterns and we have to do problem solving on the hoof. And that involves communication and team working. You work well with an anesthetist, with your scrub nurse, with everybody. But when you're wearing a face mask and we're all limited in communication, that becomes very, very difficult. We are all part of crisis resource management, isn't it? So that's what we do. We deal with patients, we deal with bleeding, but we're all working on our small working memory, which helps us make decisions, and it has a finite capacity. And it is subject to interference. Evidence has shown that is affected by all the various factors. Do you think any of us were affected by all these factors during the pandemic, in addition to what we normally do? Yes, we all come to work stressed. Am I going to take something back home to the family? So what does that have impact? It reduces your working memory. What you could do in 2 seconds now takes you 2 minutes. That's the impact of the human brain. We all do things very well, but there's no point in us doing it in a dissociated fashion. We have to work together as a team. The surgeon, the anesthetist, the scrub nurse, all have to have a shared mental model. We need to have a strategy of how we deal with the patients, how we get on with it. In summary, COVID has had an impact. We pride ourselves of a cancer treatment pathway, reduction in the time with the Manchester Optimum Lung Pathway, RTT, but all of that has taken an impact because of the capacity issues. ICU has been full. You have theatre and recovery converted into ICU. Our staff have been redeployed. Sam told you that earlier on. And the patients who require an ICU are the ones who would normally come in and have the operation and go home in day 4, but we are telling those patients we won't do it because of the pandemic. We are slowly getting back to operating on these patients with the ITU booked up. In terms of surgery, Do we do VATS or open? We choose to do it open because it is quick. We can't do 3D VATS because the minute you put a visor on, you can't see things in 3D. So you have to go to conventional VATS. There is patient choice. Some patients will tell you, look, I'm not coming anywhere close to the hospital. Equally well, there are patients who will say, yes, you're telling I'm 80 and I have a higher risk of dying. But if I stay at home, there is still curtains down with the cancer. So what we tend to do, candidly counsel them. They're all self-isolating before surgery. They're brought into Glenfield to have swabs. We do a preoperative CT. We try to convince our radiologists to have a CT done before surgery. This has a clinical change because patients have had disease progression and have not had the operation intended. And patients have been sent home because the nodule, which was PET positive, is no longer there on the scan. So all of these things have changed. We also do an on-table bronchial lavage and send it for virology. So this is our team. Can you see the different types of masks? There is Sarah wearing the Traeger mask, Jose with the aviator. We all feel like we are in Top Gun taking our masks and things, but communication is very difficult because with the respirator, you have a constant flow of air, which is hissing in your air. So you can't actually listen to people. So decision making is difficult. Where do we go forwards? We have to have a streamlined pathway for theaters. In the ward, we have COVID-free area and COVID suspect or COVID positive area. We have a realistic list. We can't double up. We can't bring the second patient in. And it also has an impact on training. How do we provide training in this time? With the ward management, there is one particular thing to highlight. All thoracic patients have drains. Normally, we will put them on a flutter bag. So we use variety of drains. They go home with a flutter bag. But now we don't do this because they are a risk of aerosol generation. So patients are put on the Topaz drain, which is a closed system with filters. COVID has had an impact on trainee well-being. This is a survey which one of my registrars did with the society, which showed on a questionnaire which had a 64% return rate that all the trainees, 63% felt they were concerned about their physical well-being, 32% were concerned about their mental well-being. There had been ethical dilemmas in those trainees because either they were redeployed in a different area because of the pandemic or they were not happy with the decisions which were taken because of the pandemic. They all have reduced time in theatre, reduced time in MDTs, and they were all concerned about the impact on their training, and they all are planning to extend their training time. So there's a variety of impacts, not only on the patient, but on the trainees. Research has been suspended. We only are doing COVID-focused research. We have a big, robust research portfolio. Everything's suspended. Our thoracic research nurses redeployed for COVID research. But we have used the opportunity to partake in an international registry of COVID patients, which has just been published in the Lancet. It's very nice to be part of it. It was an analysis of 1,128 patients across all the surgical specialties, which has kind of given us an idea, but it also highlights the fact across all specialties, 30-day mortality with COVID pandemic is 38%. There's no running away from this truth. But you choose nicely and you are selective. So we are still in evolving situation. You still have to be careful and you have to do it. And you are guided by the guidance which come from the colleges. So Amrita already told you the guidance on CTs changed. The 4 colleges offer cohesive statements in terms of pre-op screening, training, pay, staff will be PPE, so we are guided, and the situation changes by the day. So I'll come back to my original slide. The only difference is COVID-19 is here, and there's no quick getaway from it, and we can't let it conquer our spirit. Thank you.
Thank you, Sri. Thank you. It was a very nice presentation. And would you like to introduce the girls? Sri, please.
Absolutely. It is with greatest pleasure I introduce our thoracic nurse specialists. They are a joy to work with. Joe and Sarah, they are the communication hub or the nerve center of our practice, because every patient who comes into hospital wouldn't have come into the department without crossing their path. And they keep us always on our toes and make sure our patients get the best. You will be delighted to know they've been running a patient experience day for the last 7 years. And it's one thing which other units should consider, bringing our patients and getting an interactive feedback. Over to you, ladies.
Thank you, Sri. That was a really nice introduction. And thanks for letting us present today. We just wanted to take this opportunity to talk to you about the challenges that we've faced within our service over the past 12 weeks. If you can move to the next slide, please. So as you're all aware, COVID-19 hit us out of nowhere, and the demand on the NHS has been huge. The need to adapt to new findings and newly released evidence has been continuous, really. We've often felt like we're just about getting ourselves on a handle of a new change when updated information is released and we're back at square one. When we were putting these slides together, we took the opportunity to reflect about our understanding of a pandemic, which admittedly is was quite basic. And we think that going forward, the topic really should somehow be incorporated into the mandatory training of nurses or nurses in general. Next slide, please.
In the TNS team, we started to notice an increase in the patient phone calls around the end of February, beginning of March time. It was at this point that questions mostly came from previous surgery patients wanting reassurance and advice. The most frequently asked questions are what we've identified on the slide. What are the symptoms? What should we do? Will the surgery go ahead? Can I still go to work? Am I vulnerable? And will you still see me for follow-up? This was really difficult for us as a team, as we genuinely had no more guidance or information than what was available to the public. We would support and listen to their anxieties, signpost them to government websites, or to act on any symptoms should they arise. Questions over the course of the next few months increased tenfold. Patients planned for surgery began to worry that they would not get their surgery, or if they did get it, would they be coming into a high-risk environment? As a team, we were as open as honest as we could be. Operations were still being planned and surgery going ahead, but it was at reduced capacity and changing on a daily basis. We decided to pre-warn the patients that this may be the case to try and ease anxieties around the same-day cancellations. But the patients understandably had so many concerns about what this meant for their health. But it wasn't just their health that they were concerned about, it was social, domestic, and employment circumstances. Next slide, please.
A massive and sudden change to our role was the way in which we conducted outpatient appointments. For us to be able to achieve the management of clinics, we changed our working pattern. So there was 2 of us in on a Monday and Friday, and all 3 of us were in the rest of the week. So we knew that Monday to Friday, the office was covered between 8 and 5 o'clock. The changing of clinics was very much a learn-as-you-go situation. Our main priority was to ensure all patients did not fall off the radar with their follow-up, and knowing that this was not going to be a short-term situation, we knew we couldn't simply postpone follow-up appointments. Patients still needed to be assessed. We tracked every clinic and contacted every patient to let them know of the changes. We kept and documented the outcomes. And obviously we had a lot of help with this, particularly from the consultants, the registrars and the admin staff. There was also a lot of debate as to whether or not the patient should still be attending for imaging, but advice was for the pathway to be maintained as much as possible. So when we called patients, if they were due a chest x-ray, we would still ask the patients to attend if they felt comfortable to do so. And we would also ensure we documented if they were to decline. The common reasons for this were either the patients were shielding themselves or they were just too scared to come into hospital for the fear of catching COVID. We also found that many CT requests had not been processed and were being re-vetted. We have recently discovered that the CT department communicated delays to the referrer, but this was not picked up in time and often only the week of or few days before the clinic itself. So how we overcame this was by emailing. We have an imaging escalation mailbox, and we put the full patient's history and why they needed to have that CT or image. And I have to say the radiology department have been really helpful and accommodated this, and lots of the scans have been done near to the date of their clinic as possible. We think that although it has been a huge undertaking and the process for the thoracic nurses to call all the patients, that it has significantly reduced their anxiety and to let them know that they're not forgotten. We would also ensure that when we phoned the patients that they were coping okay, not just mentally, but also practically, with things, for example, like shopping and prescriptions, because we could signpost patients if they were struggling. Most patients have been really thankful and said that they felt really looked after by having that phone call with our team, plus knowing that we were still within our roles because we were never deployed, and that they can contact us at any time. Next slide, please.
So after the initial influx of phone calls with just general enquiries, the government announced that they were going to be sending letters to those people that they considered to be extremely vulnerable. When the government did this, our phone lines practically rang off the hook. There was so many patients asking if they were going to get the letter, or if they hadn't got a letter, why hadn't they got a letter? And at this point, the information that had come through to the NHS and the individual trusts was quite limited. We were only really hearing what the public were hearing through the press, TV, newspapers. So to try and inform our patients on something that we knew very little about was personally quite difficult for us. We did look into it more. We spoke with different specialist nurses, and we decided to direct patients back to the government website, where we felt that they could they could self-refer for the vulnerability letter. A lot of patients were also saying that their employers needed proof of fitness to work, and that they needed the letter to show their employers that they couldn't. So we said that they should speak to their occupational health departments and ask for individual risk assessments. I know within our trust, lots of individual risk assessments are taking place. So if nurses have to self-isolate, even though they don't have 12-week letters, then that's a way around that problem. But it was, I think, on our feet kind of situation. We didn't really know how to answer it. I mean, we're at the end of the 12 weeks now, so the phone calls have stopped. But at the time, it was quite overwhelming, the amount of patients that were expecting these letters that hadn't received them through from the government. Next slide, please.
It was decided that all pre-op patients needed to be screened for COVID-19 prior to admission. Initially, this was 7 days prior to admission, with the CT on day of admission, which has already been discussed. The thoracic nurses set up a nurse-led clinic 3 days a week to carry out the swabs at the appropriate times. So we've got results back so that we could facilitate this. When it changed, it then changed that they wanted the swab 3 days prior to the date of admission and the day before surgery, and then changed again to 3 days or 72 hours before surgery. And then, as discussed earlier, the CTs weren't required. All of these decisions made on guidelines and not policy, so we try and facilitate them as much as possible, but it's not always that easy to do because of the clinic availability, especially at weekends. We do endeavour to ensure that the time frames are met where possible, but like I say, it's not always easy. However, changes to surgery dates at the last minute, for numerous reasons, can make the patient, it means that the patient can have multiple visits for the swabs. Surgery slots are still dependent on ITU availability. Obviously, it depends on the patient as to whether the ITU bed is deemed important, but we should always have the facility there because we don't know what's going to happen. And that has been very changeable too throughout the pandemic. With regards to follow-up appointments, we've adapted our clinics and we carry on adapting clinics, and it's an ongoing challenge. As we move to being more able to offer face-to-face appointments, the thoracic nurses are looking at clinics to identify patients who benefit from attending for these face-to-face appointments. It's often for new diagnosis or for receiving bad news. But it means that the clinics are keeping their the people that attend there to a minimum. So patients aren't allowed to bring somebody with them, which can be more challenging as well, because if they're at home and being given news over the phone, they can at least have somebody with them to support them, whereas they come to clinics and are expected to come on their own, and they've not got that support there. And also, when you're given bad news, an extra pair of ears can be an invaluable resource for them. It's also reorganising the clinic times to allow for cleaning rooms in between and making sure that we can socially distance and things like that. It's also making sure that patients don't come early to clinics because of the limited space in the waiting areas and being able to socially distance in the waiting rooms. Or one thing is that perhaps ask the patients to wait in the car and then we call them at their actual time when we're ready for them so that they can come in. Another thing that has been affected is the availability of translators for patients where English is not their first language. Obviously over the phone, and that's very challenging. I think we're now getting to a point where we can start to reintroduce those. Moving forward with the clinics, we're continuing to check that CTs or other investigations are done so that patients don't have wasted clinic appointments. An area where the thoracic nurses service was developing prior to the pandemic was patients being discharged with chest drains in situ. We were looking to expand our role and develop nurse-led clinics to facilitate patients going home with chest drains, but this has had to be put on hold as we're not able to give the support needed, so the patients therefore have to remain in hospital until all drains are removed, which then extends the length of stay for them. Next slide, please.
So this is a very brief insight as to the ward challenges. I know there's a lot more than I've highlighted on the slide, but one of the things is obviously dissemination of information and updates to ward staff. So communicates via email, and a lot of our nurses don't have time to check emails throughout their shift. So we're relying on one person to update the rest of the team, and an ideal time to do this obviously is at the start of every shift, in handover, communicate any changes, make sure everyone's up to date on the current practices. We've also got challenges of getting the COVID screens back in time for admission. So in an ideal world, we'd like to admit everybody having already received the results of the screen. So obviously only if they're negative. If they're positive, then surgery is delayed. But at the moment, we're not getting the screens back in time. So sometimes the patients have to be nursed in a side room until that result is available. So that puts pressure on the ward to ensure that those side rooms are available. We've only got 6. And obviously some of those do have patients that are in there for other reasons, or if they're post-op and they need a HDU bed and the only availability is a side room. It just means that the pressure for beds is increasing. We have talked about making COVID-free bays, and we did have some doors put up to separate our ward into a clean space and an unclean space. But at the moment, we're still trying to figure out how best to utilise that. So for the time being, unknown or infected patients should be in a side room. The next point is PPE. So I think we've been quite fortunate at this hospital that we've had PPE readily available to us. The matron of the day and the nurse in charge have been going around the hospital, making sure that the wards have got enough PPE, delivering masks throughout the day. So we've also had donations from patients who have been making masks and visors. We've had from Leicester Grammar School, so that's been really generous and really helped with that. The next point is physio. So obviously a vital part of our patient recovery is physiotherapy. Physiotherapy uses a lot of aerosol generating techniques. So the ward has created a side room that is just for physiotherapy. So they can go in, the patient can go in, have the physiotherapy, whether it be birding or just cough inducing. Then they go back to their bed space, the side room is completely cleaned down, and then the next patient can go in. Finally, the biggie one for us has been visitors. Obviously, patients aren't allowed to have their relatives visit them on the ward, which is emotionally, psychologically, it's been really challenging. The ward are just helping as best they can, really. We've had iPads delivered to the ward so that we can do FaceTime. We've encouraged visitors to telephone the ward more often, and the nursing staff have obviously been really understanding and helpful to them over the telephone, offering that extra bit of reassurance where they can. Next slide, please.
So how have we felt throughout this last 12 weeks? As the slide states, we've felt very responsible, emotional, overwhelmed and helpless. But we've recognised that we are advocates for our patients, and we have shown empathy in this chaos and how apprehensive we all felt at times. We are very lucky that we work with a fantastic team, our thoracic family, and particularly myself and Hayley and Joe. We've really taken out time throughout the day to check each other that we're okay. Do we need 5 minutes? You know, is everything okay at home? Because we work here with COVID-19. We get in the car, we switch the radio on, it's COVID-19. You get home, you put the TV on, it's COVID-19. In some ways, in the height of it, we never got a rest from it. But we are a team. One thing we never did is we never had a break. We never took breaks. We never had a lunch break. Now we do. We go for a walk around the grounds of the hospital. There's a secret garden here at the Glenfield where we've often gone and sat, and it's just been quite emotionally letting go of just having that half an hour just to unwind, really. We've also had support, and we've also given support to our other CNSs, not just here at Glenfield, but the other trusts that we deal with in Peterborough, Northampton, Kettering and Burton. And some of the CNSs themselves are at home shielding. So again, we've picked the phone up and we've asked them, are you all right? How are you feeling? And I think it's one thing across the board, particularly we've noted here at Glenfield, is how everybody has been aware of everybody and the kindness that we've seen. Patients have also phoned up for purely the reason of, are you all right? We've been thinking about you. Please stay safe. You're doing a fantastic job. And they've sent us gifts, like Hayley briefly mentioned, but the cakes have gone down very well. Sweets, we've had hand creams. Some people have bands with buttons so the face masks can go on. So it has been a very challenging time, but between us all, I think that we have just taken it on board and we've really looked after each other. And I think that's come across from Glenfield, certainly. Next slide, please. So that's the end of our presentation. I hope it's just given you a little bit of an insight into our role and how we've had to turn ourselves around and very quickly, and hopefully we've still managed to support the patients in what we've done over the last 12 to 14 weeks.
Okay, thank you so much. And before I go to the questions, just I want to tell everyone we have a next webinar about the health and well-being for healthcare practitioners during COVID, virtual yoga and also acupuncture session. If you are interested, please join us.
Thank you very much, ladies. For those of you who are in the comfort of your living room joining this presentation, Sarah, Hayley, and Joe have come into work so that they could work together as a team to give you this presentation. So we can't clap for you because it'll create a cacophony of noise from mics, but hats off to you for your commitment of giving away a Saturday evening away from your loved ones to come and join us. Any questions for the three lovely ladies?
I'm again Annie from Papworth Hospital, Cambridge. It's lovely to hear from them, and so lovely that they really did the best job as specialist nurses. And I'm also one of the specialist nurses. So I have to ask a question: has anybody worked from home during this period?
We've not really needed to at the moment now. In the trust, I think there has been some exceptions, and I know one of our secretaries is for childcare. She's had to change her work pattern quite significantly, but not working from home, still expected to do all of our hours within the hospital for the time being.
All right, okay. I just wanted to know, how did they feel working from home, away from the team? How did they mentally, and also getting the job done, how did they feel? That's what I wanted to know.
So we've had some
From
stuff
home,
being
it's not very
moved.
challenging because clinicians, a lot of us have been working from home where possible. And it's surreal. You have to discipline yourself to do what you want to do.
Yeah.
Because when you're at work, it has its advantages, it has its disadvantages. Because I'll go to give a results to the thoracic nurse specialist, and I'll end up chatting for 5 minutes and catching up on the gossip, and then come back to do what I'm doing.
Yes.
Whereas at home, you could step out into the garden and then you get distracted. So it needs a bit of discipline. But as far as the nursing staff are concerned, they all have been on the shop floor.
Okay, thank you. Because I feel stressed out, because sometimes I feel isolated and you don't really see the people working. So if you sent out an email, if you didn't get a response, you get frustrated within that particular period of time if you get a response. So so it's really stressful. So I just wanted to see if they've got any more tips for me. Thank you.
I think we have to take this opportunity to thank our speakers, Sam, Hayley, Joe, and Sarah. Dr. Bajaj has left us. So thank you all for providing a wonderful session. And thank you, Buna, for putting it together to keep all our staff engaged and sane in this testing times.
Thank you so much, Sri.
Yeah, thank you.
Thank you.
Thank you. Thank you so much for coming. Thank you, Samir. Samir, do you want to say anything?
I was just going to say thank you for the organizers. It was very well run, and thanks for giving me the opportunity. It was lovely to be part of this webinar. Thank you.
Thank you so much for everyone coming.